So we're here at the BGICC, a very important conference in Egypt, in Cairo, discussing various aspects of breast cancer diagnosis, treatment. I gave 2 lectures yesterday on the management of the axilla. And the management of the axilla for patients with early-stage breast cancer has undergone significant revolution in the past 25 years. Up until the turn of the century, we used to do axillary lymph node dissection electively to assess the axilla for many years, over 100 years, based on old studies by William Halsted, radical mastectomy. And then randomized clinical trials in the 70s demonstrated that electively removing all the axillary nodes does not improve survival. And that was a big change. And so we still were continuing to do axillary dissection then because we didn't have any other way of dealing with the axilla. But progressively, because obviously axillary dissection also provides a very good local control of the disease in the axilla if it's macroscopic disease. But eventually we realized that we don't need as many nodes to be removed to get the information that we need to manage the patient. And along came the concept of sentinel lymph node biopsy, which is a selective removal of few nodes, usually about 2 or 3, average about 3. They give us the same information, provides good local control of the axilla as well, and then spares the patient the morbidity of lymphedema and other sequelae of axillary lymph node dissection. So over the last 20 years or so, there has been significant evolution in the management and applying sentinel lymph node biopsy to most of the situations that we used to do axillary lymph node dissection. So for example, for patients with clinically non-negative axilla, if their sentinel node is negative, we do not do an axillary dissection. And that was based on randomized clinical trials showing no difference in outcomes. And subsequently, we start thinking that maybe if 1 or 2 lymph nodes are involved, when the axilla was clinically negative, meaning that the surgeon did not palpate lymph nodes, maybe we can get away without removing more than the sentinel lymph nodes. So a series of randomized trials as well took place that demonstrated very similar outcomes, whether you did the sentinel lymph node biopsy, 1 or 2 sentinel lymph nodes were positive, and then did the axillary dissection or not. So that changed a lot because it decreased further the use of axillary lymph node dissection for the management of these patients. So clearly an evolution sparing the patients a lot of morbidity. Now initially the studies were in patients treated with breast conservation where they also received radiotherapy, but subsequent studies also included mastectomy patients. So we now feel comfortable that we can offer this to patients if they have a clinically negative axilla and 1 or 2 positive lymph nodes on the sentinel lymph node biopsy. We don't perform the axillary dissection and the outcomes are the same. And another trial also showed that if you, instead of taking the additional non-sentinel lymph nodes out, you radiate the axilla, the outcomes were also the same. So we have the option of just not doing the axillary dissection and observing the patient with just breast radiotherapy. Also, we have the option of radiating the axilla to provide good local control for patients, let's say, that have a little bit more burden of disease. So with that, again, we diminish the use of axillary lymph node dissection. And another way that we have done that is also through the use of neoadjuvant chemotherapy. Neoadjuvant chemotherapy early in the 1980s has shown to be equivalent to adjuvant chemotherapy. So randomized trials have shown that neoadjuvant chemotherapy is as good as adjuvant chemotherapy, but it had some clinical advantages. For example, it would shrink a tumor and convert a mastectomy patient to breast conservation. And eventually we realized also we can do the same thing with the axilla. If the axilla is involved and we give neoadjuvant chemotherapy and sterilize the lymph nodes, perhaps we can avoid axillary lymph node dissection. So we have shown, again, in a series of studies and clinical trials that if the axilla is clinically negative, if the patient gets neoadjuvant chemotherapy, you can perform the sentinel lymph node biopsy after. And if the sentinel node is negative, then you don't have to dissect. The performance characteristics are very similar. So we expanded the indication even for that group of patients. And then we pushed even further. We tried to assess whether if the patient had positive nodes before, and we biopsy them, we know they're positive, but then she gets neoadjuvant chemotherapy, and now the lymph nodes are clinically negative, and we perform the sentinel lymph node biopsy, then if the sentinel lymph node is negative, actually we wished to eventually not perform an axillary dissection in this setting. But of course we had to demonstrate the safety of that and what is the false negative rate of sentinel lymph node biopsy in that setting. And it turned out that the sentinel lymph node biopsy rate was a little higher, but eventually by optimizing the approach of the axilla in these patients, For example, by identifying the node that was biopsied before, the so-called clip node, and removing this lymph node along with the sentinel lymph node biopsy, we're able to drop the false negative rate even further to about 3% or 4%. So this is pretty much now becoming the standard of how we manage these patients. We map the axilla, we do the sentinel lymph node biopsy, and we also localize and remove the node that was biopsied before. And we do this in a variety of ways that we can insert clips and radio frequency chips to identify it. And with that, we're very accurate in finding the disease in the axilla, but we spare also patients that have negative sentinel nodes after neoadjuvant chemotherapy, the full axillary lymph node dissection. So that's a further advancement in decreasing the role of axillary dissection. And sort of as we look into the future, the next step would be to say, well, if the patient's node became clinically non-negative after neoadjuvant chemotherapy, but the sentinel node is still positive. Nowadays, the standard is to remove more nodes, do an axillary dissection. But the question is, do we have to? And a randomized clinical trial that has been conducted assesses this exact question. So we're waiting now in the next year or two to find out whether maybe in that setting, doing more surgery may not make a difference. Because these patients, of course, they get radiation because they still have positive nodes. So that's sort of the next step to even carve out another group of patients that maybe wouldn't do axillary lymph node dissection. And the last thing I talked in my lectures also was, if you end up having to do an axillary dissection, then are there ways to decrease in the morbidity, particularly lymphedema? This is the morbidity that the patients fear the most. And there have been some ways now that we've developed to actually preserve some of the lymphatics in the axilla when we do an axillary dissection by identifying them through performing what we call two options as axillary reverse mapping, where we inject some blue dye in the arm, and you see the nodes that turn blue, and you tend to preserve those nodes because these are not nodes that drain in the breast, are nodes that drain in the arm. And if you do end up taking them out, you can approximate the lymphatics surgically to make them anastomose again. That's one approach. And the other approach is the so-called lymph procedure, lymphovenous bypass, where under microsurgery, when you remove the lymph nodes in the axilla, you previously inject dyes in the arm, stain the lymphatics from the arm, and then anastomose the lymphatics to small veins in the axilla to reestablish the lymphatic circulation. And this is also a promising method that we're trying to use more and more now, and hopefully we get more data as well to prove that in fact lymphedema is less with this approach. So we're trying to minimize the morbidity for the patients while getting the information that we need from the axilla, and that was essentially the topic of my two lectures yesterday.